Hi everybody, and welcome to the EuroELSO 2021 Virtual Congress. My name is Jesse Wouters, and I'm Medtronic's Extracorporeal Therapies Training and Education Manager for Western Europe. During this session, organized by Medtronic, we'd like to take the opportunity to stay further connected with all our healthcare professionals by sharing interesting up-to-date knowledge, innovative product information, and clinical expertise directly from within the field. In this session, we are going to focus on variations in patient strategies for dual lumen cannulation. The experts, which I'm going to introduce to you in a moment, will share their expertise in usage of dual lumen cannulation on different types of patient conditions. Let me now introduce you to our faculty. We have Professor Hoetzenecker from the University Hospital of Vienna in Austria. Later on in this session, we will use Professor Hoetzenecker for his expertise in the panel discussion. Then we have Dr. Bush from the Johns Hopkins Hospital in Baltimore, USA. Further on, we have Dr. Staudacher from the University Hospital of Freiburg. And last but not least, we have Dr. Schweiger, also from the University Hospital of Vienna in Austria. Okay, back to the session now. And let's start with our first presentation. Dr. Staudacher will share his experience on the usage of the Crescent Jugular dual lumen catheter in Veno-Venous ECMO patients. And with that said, I'm very happy to say the floor is all yours, Dr. Staudacher, and you can start with your presentation.
Dear colleagues, dear panel, I'm very happy to be here, part of the session, and to talk a little bit about our experience with dual lumen catheter in VV ECMO, and especially with the Crescent cannula. First of all, these are my disclosures. I worked together with these companies recently, and also I will receive a compensation for this talk. Since I'm the first speaker, please allow me to show you one picture of the Crescent cannula. It's a dual lumen cannula for Veno-Venous ECMO, which is implanted through the right internal jugular vein. It's advanced through the superior caval vein to the inferior caval vein. It has two draining sides, drains blood from the inferior caval vein, from the lower part of the body, and from the superior caval vein, and it returns the blood directly to the right atrium. When I was preparing this talk, I went through my older publications, and this was a poster that I presented 2014 at the ECMO, and we were reporting on the first 50 patients that we did with transjugular cannulation during ECMO retrieval in hospital other than our own. And we would show that even out of our hospital, it was a safe way to cannulate people with a dual lumen catheter. It's also important to know that this is not something very new. It's been out there for more than 10 years. And starting from 2011, we've been using dual lumen catheters quite frequently in our hospital. This is data from the medical ICU I'm working on, and this is all the VV ECMO cases that we did over the years. You see 2010 to 2019, this is the number of cases we did. And you see that per year we're doing roughly 30 to 40 ECMOs. And in light colors, you can see ECMOs that we cannulated with a transjugular dual lumen catheter. And in dark, you can see those which we cannulated other than dual lumen catheter, mostly by FEM. And perhaps this is my second disclosure. So I'm a believer in the dual lumen catheterization, and we have now experience of more than 250 patients that I can report on. And when we do the dual lumen catheterization, we use transthoracic echocardiography in order to guide the implantation, and later on the ICU also to see if the cannula is still in place. This is a typical image of a transthoracic echocardiography. You see the liver, and you see the inferior caval vein, and you see the dual lumen cannula, which is nicely situated in the caval vein. And in this case, it's very easy to see that the patient most probably will be in a very good shape, and that there will be a good saturation and a good working ECMO system. But we are not only using this for cannulation and for seeing that the patients are good. We're using the bicaval cannula because we want to mobilize our patients. This is a picture of a young boy, HIV, severe pulmonary failure, but we got through the most part of it and we could extubate him, and he's still on ECMO because weaning is not yet complete, but he's happy and he's mobilized and he can talk to his mother on the phone, and we are quite happy with such cases. Also, we like to do a lot of cycling with our patients in bed, and this is very easy if you don't have a cannula through the legs. But we are not the only ones who believe that dual lumen catheterization is a great thing. This is a publication from Cologne, Germany, comparing a conventional cannulation to a dual lumen cannulation. And what they found is that the dual lumen cannulation is great, especially if you want to mobilize your patients. What they found also is that prone positioning is very easy with dual lumen cannulation, and I'm happy to hear later on the talk of Dr. Bush, because I think prone positioning is the major bullet that we have in fighting the coronavirus disease. But I have to be honest, it's not always so easy with those cannulas. We have a lot of problems with suction, especially if the only part of the cannula which can drain blood is the end of the cannula. And we have problems with dislocation of the cannulas. Here you see transthoracic echo again, you see the liver, the caval vein, and you see the big liver vein, and sometimes cannulas can dislocate into the liver vein. This is quite tricky to handle afterwards and to reposition the cannulas again. So we also have problems with very large male patients when the cannula is not long enough. Here you can appreciate a CT image of severe pulmonary failure. You see the dual lumen cannula, and you see that it ends right above the diaphragm. This means that we have a lot of recirculation in these kinds of patients, and if we can't reach the inferior vena cava vein, this is not a good way to cannulate the patients. Therefore, I was quite happy to have the possibility to try a new cannula, which is the Crescent cannula. For me, three things stand out. First of all, it's a little bit longer than other cannulas we were using. They were 31 centimeters, and now we can go to 34. So we can reach the inferior cava vein even in larger subjects. Second of all, we have perforations here at the end of the cannula, which allow for drainage of many different parts in the inferior cava vein, which at least for me limits suction events. And the third advantage that I see is that you have markers that you can see in X-ray images and that allow for positioning of the, or to check if the positioning of the cannula is still good. This is great if you have stuff on the ICU, which is not so familiar to transthoracic echo, but it's also good in patients where you cannot do the echo correctly because of air, which is a difficulty in the examinations. And I want to share one case of you, which I was working with a long time in the recent month. It was a 60-year-old lady. She had no relevant comorbidities, and she got infected with coronavirus during the second wave of the coronavirus pandemic in December. And first, she was managed with high flow, and as the coronavirus disease got worse, she went on non-invasive ventilation, and unfortunately, she developed a severe bowel trauma as complication of the non-invasive ventilation, including pneumopericardium and pneumomediastinum and pneumothorax. So then they called us, and we went for ECMO retrieval in this patient, and you can see here the first CT image that we got from her, and you see that she has air everywhere in the thorax and especially in the pneumothorax and the pneumomediastinum. And we went for ECMO because we thought with positive pressure ventilation we will not help her, and we went for bifemoral cannulation. And perhaps you cannot see it so good on my monitor, so I marked this. This is the draining cannula, and this is the returning cannula. This is the image we saw when the patient reached our ICU, and we were not able to oxygenate the patient very well because of that. We had a lot of recirculation. So we retracted the cannulas a little bit. Here you can see that the draining cannula is now below the right atrium, but still we had problems in managing high flows, which this patient needs. And she had a very high respiratory drive, and so a lot of suction events, especially during coughing, occurred. So after 3 days, we had to go for dual lumen cannulation through the internal jugular vein. And this is a CT scan, not on day 3, but on day 10. And you might appreciate severe pulmonary failure. And you might see the Crescent cannula and the opaque radio markers that make it very easy to see where the cannula is situated. Still, it was a severe pulmonary failure, and we had a lot of days. And on day 60, this patient still was on ECMO. You see that she had a giant pneumothorax again on the left side, but you might also appreciate that the Crescent still is exactly in the same place that it was 2 months ago, and it is the same cannula. And on day 70, still the patient is on ECMO, but she was decannulated. She was not dependent on the respirator anymore, which we were very happy because of all the pneumothoraxes that she had. And later on, we were able to wean her and dismiss her for rehab. So we were able to keep her actually 78 days on the Crescent, and we had a lot of problems with her. She had superinfection, and she had acute kidney failure and the pneumothoraxes, but the ECMO would run all the time very smoothly, and we were happy that we could get her over this very tough period in her life and dismiss her to rehab. And this is the other, like the last 10 patients that we did with the Crescent. And you can see here, this is the days on cannula that we kept her, and the 6 patients were already weaned or deceased. And this is the last 4 patients that we did, all ongoing. And I made this picture 4 days ago, so you can add 4 days. And this is a very good cannula, and it's working for long times in our hands. So to sum up, what can I tell you about our experience with the Crescent? We try, like in all ECMO patients, to keep the indication for ECMO as close to the Jugular trial as possible. When we cannulate, we go for a bedside cannulation, and we use transthoracic echocardiography for guidance. We do it with 2 intensivists, 1 nurse and 1 perfusionist. And when we go for ECMO retrieval, we like to take the intensivists and the perfusionist with us, but we depend on local nurse stuff, and it works quite well. When we cannulate, we obviously, as you saw from my data, we go first for the transjugular approach if it's possible, and this is true for all the patients that we cannulate here, but it's especially true for all the patients that we cannulate out of hospital, because when we transfer the patients, I like to see not only the tubes, if there is a color difference, but I like to see the puncture side, if there's bleeding, if there's, the cannula still in place. And with the transjugular cannulas, I have everything, in one place. And this is one typical picture of our perfusionist and the patient that we went for retrieval. And you can see nicely that with one place, you have everything under control, and you see if there's any problem. This being said, I'm happy to share, or to have shared some of the experiences we did, and I'm happy to take your questions after this session. Thank you very much.
Thank you very much, Dr. Staudacher, for this great presentation. Now let's go along with our second speaker of today. Welcome, Dr. Schweiger. And Dr. Schweiger will focus on the usage of the Crescent jugular dual lumen catheter for bridge to transplant patients. Please, Dr. Schweiger, you can share your presentation now, and I think we are all eager to hear about your clinical experiences.
So thank you, Jesse, for your introduction. Dear colleagues, I'm very proud to be here and to be able to share our recent experience with bridging patients to lung transplantation with you. And I will put, of course, also a focus on awake strategies during this talk. So the evolution of bridge to transplant is really enormous during the last years. We provided mechanical ventilation in the early years to those patients, kept those patients sedated during the waiting for lung transplantation. And now we're initiating in an early period of the deterioration an awake ECMO, keep those patients without ventilation, keep them active during their waiting time for lung transplantation. And this has several reasons. First of all, we know that the respiratory muscles get atrophic very soon after we initiate ventilation. So this is especially true for lung transplant recipients who will need their respiratory muscles immediately after transplantation. Furthermore, the mechanical ventilation itself has some effect on the lung tissue. There is some injury you can produce by especially high pressure ventilation. Is of course also a reason to abstain from mechanical ventilation if it's possible. Furthermore, there's a ventilation perfusion mismatch during mechanical ventilation, especially true for the dorsal areas in the lungs. And this is another reason why mechanical ventilation is a rather unphysiological condition. And last but not least, there is a certain risk that the patient will acquire a ventilator-associated pneumonia, which has not only the risk for mortality and significant morbidity during the stay, but confers also some costs which are associated with this early complication. So in the context of lung transplantation and in patients with end-stage lung disease, there is even the question whether mechanical ventilation is possible at all. So like in this patient with end-stage lung fibrosis and high output air leak, mechanical ventilation might not even be possible at all. And the only way to save this patient is to initiate early during the deterioration a ECMO in this patient. The ECLS bridging to lung transplantation using ECLS devices is clearly a game changer. We are now able to do ECLS bridging starting from pediatric patients to adult ones. We can insert those devices without intubating the patient at all. We can put them on Veno-Venous or Veno-Arterial ECMO awake. And during the transplantation, during the waiting time for transplantation, we can keep those patients awake and active. And also, if patients are admitted or are referred from distant hospitals, which are not able to insert an ECMO in the patient, you have to provide the best care to those patients by going to those remote hospitals, putting them on ECMO, and then transferring them back to your own center where you have the experience in treating patients with end-stage lung disease. We have two options. Either we use a dual cannula approach, typically femoral or femoral jugular configuration, or we use dual lumen cannulas. Question is, what is the advantage of the dual lumen cannula? It clearly facilitates that you keep your patients awake and mobile during the bridging period. This is a patient who is waiting for lung transplantation right now on one of the ICUs at our hospitals. You can see that the patient is not only able to eat, he is communicating with his smartphone with his relatives and his wife. Moreover, he's able to do some physiotherapy using his arms. And something that is for sure not that easily possible with a femoral cannulation is that he's able to do some cycling in the bed and stays active like this. So there are a few technical considerations for awake dual lumen cannulation I want to put an emphasis on. Those patients with end-stage lung disease referred for awake ECMO cannulation have a very limited respiratory reserve, of course. So you have to keep your time when you handle those patients for cannulation very short. This means that at a certain time point, the patient will further deteriorate when you lie them flat and manipulate the patient. So awake Veno-Venous ECMO cannulation, it's also true for awake veno-arterial ECMO cannulation, is critical. So you have to keep this time frame as short as possible. This brings me to the next point. You want to have a immediate and safe confirmation that your guide wire is correctly placed in the cava inferior. So we developed SOP at our department for those awake dual lumen cannulations. This includes that we do a team briefing with the whole team in advance. Everybody should know what happens next. Of course, all the equipment is checked, and we prefer to be 2 surgeons or 2 operators, sterile, scrubbed in, together with scrub nurse, because you're going to need all those hands for a rapid cannulation. The patient is, of course, awake, so you have to maintain a close communication with the patient. You have to use local anesthesia, and you can consider mild sedation to take away the stress of the patient if it's necessary. And a pre-existing central line in the right jugular vein is, of course, favorable because you further decrease the manipulation time at the patient. Regarding the imaging, we have a standard also at our institution for this. We use fluoroscopy in the operating room. And if we do it on the ICU, we use mobile X-ray devices to confirm that the guide wire is still in place before we introduce the cannula. So sonography is at our institution not recommended anymore because it's highly user dependent, and it takes some time to place the cannula with it. The environment we choose is, if we have it available, we book operating room, and anyway, if you have to do it in the operating room or on ICU, you should provide a calm atmosphere to the patient who is anyway very stressed. So this is the setting in the operating room. You can see we are 3 people on the table, scrubbed in, 2 operators, 1 nurse, and do the placement of the cannula in fluoroscopy. And this is how it looks like on ICU. I hope you can see that here the guide wire is correctly going straight to the vena cava inferior, and afterwards you can safely insert the cannula. So in the last part of the talk, I'd like to give you an update on the bridging experience at our center during the last 5 years. We published the bridging experience of the last 20 years in a very recent publication. And what you can see is that we were able to drastically improve the survival of those patients compared to the very, very first eras when we used ECMO in the bridge to transplant setting. So I will focus in this talk on the last 5 years to provide you with the updated numbers. So right now we perform about 10% of our transplantations in patients who are in a bridge to transplant setting. Needless to say, this will change completely in 2021 as the 3rd wave of COVID-19 hit Austria now, and we are currently performing this year about every 3rd transplant in a bridge to transplant setting with ECMO. So I summarized the experience during the last 5 years at our center. These are only patients who underwent transplantation after bridge to transplant. 51 patients in total at a median age of 38 years. The range is from pediatric patients to very old patients from 6 to 77 years. And the median time on ECMO support was 5 days, also with a huge range from 1 to 45 days. The majority of patients had interstitial lung disease or cystic fibrosis, and the other indications were more or less common. So I think this is one of the most central slides in this talk. It shows the used ECLS modalities during the last 5 years. You can see several interesting trends here. So first of all, we do not use pure CO2 removal devices in this setting anymore. For several reasons. First of all, we learned that those patients will require higher flows during the bridging periods, which forced us to make an upgrade in the cannulation. And the second thing is that during the implantation, we will use the venous drainage cannula also for implantation in some patients. So we need higher flow rates. So we completely stopped those CO2 removal devices in this setting. And the second trend you can see is that the usage of the dual lumen cannula is steadily increasing throughout the last years because it gives us the chance to bridge our patients awake. Question is, how often is awake bridging possible at all? You can see here in a publication from the Columbia University that they were able to manage around 35% of the patients receiving active physiotherapy. And in this Toronto experience, are also almost 40% of the patients received some kind of physical therapy during their ECLS bridging. How does it look like in Vienna in this updated experience? You can also see here that we could increase the percentage of awake bridge patients from 25% in the early years, 2016, 5 years ago, to now constantly more than 50% are awake on ECMO when we bridge them to transplantation. And another interesting thing is during this time, we could decrease the mortality on our waiting list from 5% to 0.5%. This has, of course, several reasons, but I think one of the main reasons is that we have more experience now in which patient should we take to our institution and at which time point we should take over these patients before they start to deteriorate in another distant hospital where they don't have the experience and the possibilities to put those patients on ECMO. So does it pay off? Regarding the ventilation time after the transplant, in ours, you can see that there is a significant difference if you whether you bridged your patient awake or sedated. There is a difference in the length of the ICU stay after transplantation, also in favor of the awake bridge patients, and you can see in a less extent also difference in the total hospital stay between awake and sedated bridge patient. Regarding the overall survival, we have in this very recent series a 90-day survival of slightly above 90%. And still at 1 year, almost 80% of the patients are alive. And this in the overall cohort, so including retransplantations, retransplantations, and patients with primary hypertension. So even if you include those more complex surgical procedures. So in conclusion, if you have the ability and the possibility to put the patient awake on ECMO in a bridge to transplant setting, this should be preferred. If you choose a dual lumen cannulation, you should have some experience with the cannulation technique. It requires some preparation, and you should keep a close communication with your patient and with your team during this procedure. But however, it absolutely pays off. Those patients who are transplanted in a bridge to transplant setting nowadays have a absolutely comparable outcome compared to patients who receive an elective lung transplantation. Thank you very much.
Thank you very much, Dr. Schweiger, for this great presentation and for sharing your interesting findings with us. Let's go on to our third speaker, which is Dr. Bush. And Dr. Bush will share his clinical experience when using the Crescent jugular dual lumen catheter in COVID-19 patients. So welcome again, Dr. Bush. It's really an honor having you here as a speaker, and please be my guest to start with your presentation.
Well, thank you very much, Jesse. It's my honor to follow two very fabulous presentations we've had already today by Dr. Schweiger and Staudacher. I'm honored to speak about how we've really developed our bedside cannulation program using dual lumen cannulas, which was really prompted by our experience with COVID. Again, my name is Errol Bush. I'm the surgical director of the Advanced Lung Disease and Lung Transplant Program at Hopkins. I have no relevant disclosures. So after about a year of the pandemic, at the beginning of this month, the EuroELSO registry reported about 5,700 confirmed COVID-19 cases in which ECMO had been deployed. About 4,400 of them had already been on for greater than 3 months, and there was a reported 50% in-hospital mortality. Unfortunately, at the beginning of the pandemic, all of us really shared in sort of desperation, not knowing if COVID indications were acceptable for ECMO or what we should do or change our guidelines. Unfortunately, EuroELSO recently has given us some guidelines that really support the use of ECMO for COVID indications, as they found that we have similar mortality compared to other respiratory previously applied diseases. However, it must be cautiously used in terms of the hospital resources and capacity. But what I did notice that in prior indications of guidelines, dual lumen cannulation had been left out, and in this version of the guidelines, it was considered appropriate to consider dual lumen cannulation for COVID cases. Now, we did not alter our ECMO indications during the COVID pandemic, and really just a summary was that we utilize ECMO in a salvage fashion. So patients have to have failed very aggressive and supportive adjunctive needs of ventilatory therapy, which included high P Bartonet's protocol, prone positioning, and inhaled or other vasodilator therapies. We do have some relative contraindications of age over 60, BMI greater than 40, and being on a ventilator less than a week, with the absolute contraindications of poor neurological status or poor prognosis from other comorbidities. And over the year, with our experience for just the COVID ECMO deployment, you notice that about 2/3 of our patients ended up receiving dual lumen cannulation versus the other cannulation strategies. In general, looking at that whole cohort, we did achieve a 63% survival. And this was to discharge many of these patients going to rehab and then home afterwards. And the average being on the circuit was about a month, going between sort of 1 week to 8 weeks in general. Now, why were we really forced to do this? And with COVID, there are all these concerns with our hospital infection control about COVID transportation throughout the hospital, as well as exposure to other staff members. And this is a picture of the hallway going to one row of our operating rooms. And really, we see that during COVID, there started becoming more things in the hallway. And this is the actual operating room here, which is the negative pressure room we were required to utilize. That door actually opens into the hallway, so making it very difficult to transport patients. And then, because it is a negative pressure room, then you have to get the patient and everything with them into this holding or receiving room before actually going into the OR. And that can be very difficult with all the critical adjuncts and even ECMO that a patient might need to transport. So we determined that it was easier to figure out a safe way to be able to do this at the bedside. And so quickly, this is a room in our ICU. This is our ECMO and a mechanical support corner. So these 4 carts here are carts that were devised for the COVID pandemic that could rapidly deploy ECMO. These carts have all the cannulas, as well as other necessary adjuncts that would be necessary for ECMO deployment. But then we thought about, well, we don't really want to take these nice clean carts into our COVID unit, because the things that we don't use would really have to be thrown away because now they're contaminated with COVID. And so quickly we changed our strategy to developing just a ECMO go bag, which is a smaller bag of really only the essential things that you needed to go in to cannulate someone. And part of the issue being that we cannulate throughout multiple ICUs in the hospital. So we had to have this rapid go bag. And some of the prior presentations have alluded to, there is still some consideration over which is better, the single lumen cannulation technique versus dual lumen cannulation. Proponents of single lumen argue that it can be more rapidly deployed, may not be as positional, as we experience with the dual lumen cannulation. Dr. Staudacher mentioned that in his presentation, the difficulty that we can have with dual lumen cannulation. And some people say that single lumen cannulation actually has higher flow abilities. We haven't found this necessarily in our experience. We do see that the bicaval drainage that you get with a dual lumen cannulation seems to be more physiologic in terms of matching the patient's demands. And then by virtue of the dual lumen cannulation design, there is less recirculation, which makes your ECMO deployment or the circuit even more efficient. And as Dr. Schweiger mentioned, having the single insertion site and trying to mobilize patients in recovery, as whether it's recovering from COVID or bridging to transplant, really it does facilitate people being able to rehabilitate faster and more easily, and potentially you can use less sedation during these techniques than what might be otherwise required. So we have the experience, and I think it's more common for VV ECMO to use either the Avalon catheter or the Crescent dual lumen catheters. These are the more common catheters that are utilized. And really, in the beginning of the pandemic, we utilized whichever catheter we could get. Sometimes one catheter would be on a shortage and the other one would be available, and vice versa. But as the pandemic prolonged, then more tools became available. We really developed our preference towards the Crescent catheter. Now, it has been reported that dual lumen Veno-Venous cannulation actually has better survival outcomes, and this is not something that's been highlighted in many of our ECMO talks and conferences. But the last ELSO report in 2016 that demonstrated this data actually showed that there is between a 5 and 10% survival advantage by using dual lumen cannulation for neonatal, pediatric, and adult respiratory support. So it is something that is very overlooked. And again, we've seen in our experience, we have seen similar outcomes. Now, the differences between the Avalon and Crescent, these are flow curves that are actually taken from each manufacturer's website. And really, I mentioned we began to develop a preference towards the Crescent cannula, and you can see that even on these flow curves that the Avalon catheter tends to max out around 6 liters per minute and the Crescent around 7 liters per minute. And we found that for other diagnoses outside of COVID, that flow difference probably didn't make much of a difference. However, in COVID, we really found that patients had high cardiac outputs and high respiratory demand, that 1 liter extra difference actually made a difference. And within our Avalon experience, consistently being between 4.5 and 5.5 liters that we could achieve, whereas with the Crescent, we got 5.5 to 7 liters. Consistently, again, our preference went towards the Crescent catheter. It's been mentioned in prior presentations today about the use of fluoroscopy. I think it does have added safety, always knowing where your wire is. But again, because we're not going to the operating room, we didn't have the use of fluoroscopy that we usually would, because fluoroscopy is not allowed at our bedside. So we really had to develop an expertise in using TEE alone at the bedside for deployment. And that really necessitated having an expert echocardiographer. So we used our cardiac anesthesiologists that were on call for the day to cover these cases. And in the beginning, I would try to utilize the same cardiac anesthesiologist. So we developed this experience together and could develop pearls and pitfalls that we could be able to share with the rest of the teams later. Really, cannulation, as has been demonstrated, evolves or is based on 5 different steps. So you need to have your team that's ready and is facile in the technique, need to be extremely organized and minimize the tools that you need, access the vessel, cannulate, and then celebrate once you've appropriately positioned the cannula and you see that there's color change. You're oxygenating, your oxygenator is working, the patient's doing well. But this is how we do it and how we've been teaching people so that we can share it. And so the picture on the left here is how we make our ICU room an operating room. So first, get everything out of the room that you don't really need for ECMO cannulation, because the room is already small. Even our OR seems small. And so doing this in an ICU bed can be limiting and challenging. The bed is slid out from the head, which is to the left in the first photo. And we use a patient's bedside dining table as our operative table to set up. And then it's important to make sure that the monitor is facing outwards so that everyone in the room can see the patient's vital signs, as well as people outside of the room who may need to help if you meet any challenges. And then the echo machine is over on the patient's left. In the middle, you see where we position our team members. The operator is at the head of the bed, which in this case is one of our fellows. Me as the surgical attending, but really an assistant and really the quarterback of this operation stands to the patient's right. And so I can have a visual of everything going in the room and communicate clearly with everyone while the operator is just focused on cannulation. You see the cardiac anesthesiologist to the left of the patient, our perfusionists at the foot, as well as a respiratory therapist. And sometimes we actually have a bronchoscopy card available because at the same time, we would even do a tracheostomy because expecting a prolonged time on ECMO. And then everyone sort of pauses before we actually do this so that we're all on the same page. So how do we organize it? So really, prior to COVID, we had surgical instrument trays, which have 100 instruments in it. Again, you're only using 6 of those things. So we got rid of all of that. And really it's limited to the 4 tubing clamps, scissors, a needle driver, your access kit, saline, and suture. It's important that once you have put everything on the table to protect your access kit as well as your cannula, because these are things that you're likely not able to replace very quickly, and they have some significant costs associated with them that you don't want to lose those. And then again, before proceeding, there must be adequate communication between the team members. Fortunately, most of our patients have already had a right IJ central venous line in place when they're in the ICU. And so we're able to simply exchange that exchange that catheter over a wire using Seldinger technique. I do like to place a purse string suture around the venotomy incision before we even cannulate, such that it makes it easier at the time of decannulation to remove the cannula, or if you run into difficulty when actually cannulating, then you can easily close the venotomy and get access elsewhere. So this is a video just showing how we dilate it and the importance of it. Some people get very anxious about using this one-size-fits-all dilator that comes with a Crescent that dilates up to a 32 French in this case. So let's see here, I'm teaching our fellow how to do this. If you notice, you're able to insert the dilator, but not engage the dilator, but not insert it to stop the bleeding. But once you actually insert the dilator, you want to do it multiple times to really break up that soft tissue. Also note the operator's left hand is very stable so that the guide wire does not move and does not bow internally. Moving on, next would be how to appropriately place the cannula and then connecting it to the circuit. And again here, now that you have that large venotomy, you could be worried about the bleeding, but once you engage the cannula here and without inserting it, you actually have time to pause, that you're not going to bleed. And so everyone can get their bearings, we can communicate, making sure the cannula is oriented anterior and towards the tricuspid valve, or the anticipated space of the tricuspid valve, and then making sure that we get our hands in the appropriate position so that, we have easy placement. Now the left hand is really the safety hand, and notice the operator's hand is upside, sort of underhanded and holding the obturator with the left thumb. The assistant's hand, again, does not move, holds that wire very steady as we're cannulating. It is a very slow, controlled cannulation, and it can be seen coming down with our TEE. Now, apart again, after you've cannulated, then you want to connect to your ECMO circuit. Make sure that there is color change, and then securing the cannula, which we like to do 2 sutures on each side of the cannula at the venotomy incision, as well as that purse string that is wrapped around for later use. Now, I wanted to quickly share some pearls and pitfalls we found doing this at the bedside, as I'm sure some of our other presenters today have noted as well. but we always use a guide wire with distance markers. And that's important because one of the most feared complication with doing this, especially without fluoroscopy, is RV perforation. And the reason why you get RV perforation is that the wire is inserted into the SVC and then loops in the RV before going down the IVC. And it can be very difficult to note that the guide wire is actually looped in the RV because of other shadowing and the small wire. And especially if one sees the IVC with a wire in it, then you can often not really be suspecting that it's looped in the RV. And so if you use distance markers and make sure you only insert the wire between 30 to 40 centimeters, it becomes impossible for that wire to have looped in the RV to have gone down into the IVC. And that makes this a much safer procedure to perform at the bedside. The second thing is that we talk about repositioning, but one pearl to look out for is that is what can happen sort of after you've placed the cannula that might make you have to reposition it. And this is a COVID patient we were consulted on who did not have central venous access. So the ICU team offered to place their central venous line, but also to do our right IJ to facilitate us since we would be delayed, and we agreed to doing that. And we actually cannulated just fine. The patient was flowing almost 7 liters, hypoxia resolved. And then we get the post-placement x-ray, and there's this severe pneumothorax. Now, the patient is doing well. We would not have expected to have this pneumothorax. Do you need to do anything about that or not? Well, we always see a significant pneumothorax. We think we should put a chest tube in. So we put a chest tube in, and the patient actually started having difficulty. And so why was that? And so here, I think it was Dr. Staudacher that mentioned these radiopaque markers. And this is the atrial infusion zone that has been properly positioned under TEE. And again, the patient is doing great with this pneumothorax. And then as soon as we resolve the pneumo, notice the cannula hasn't moved. It's really actually the mediastinum and the diaphragm that's moved. And so now that atrial infusion zone is below the diaphragm. It's not positioned at the tricuspid valve, and that's why he's really struggling. So we had to quickly reposition that cannula. And this is just showing them side by side. Again, the cannula hasn't moved. It's really the diaphragm and the mediastinum that shifted. And then as I'm closing here is, how do we teach people to do this for people that don't have experience? And so clinically, we've been learning at the bedside, but we did have the opportunity to actually do this in an animal recently. And here I am teaching 2 of our general surgery residents how to do this. And this is the first time they've actually even seen this cannulation technique. And I just want to show, using these pearls that I've demonstrated here, someone who's never done this before can actually do this successfully. And again, showing those same techniques, I'm going to skip a little bit further here. You can see that she is going to be very successful and have no difficulty doing this, even in a pig that we thought may cause some challenging. This was an emergent pig COVID, or not COVID case, but an emergent case that I needed to go and put this pig on ECMO. And so again, you see here that she was very successful and used those same techniques. And so I'd like to just thank everyone that's been very instrumental in developing our bedside program. Dr. Chaz, the cardiac anesthesiologist I mentioned initially, we did most of these together, and then have been able to disseminate this technology and these techniques to the rest of our team. Thank you.
Thank you very much for this excellent presentation, Dr. Bush. We all enjoyed it. Next, Dr. Bush is going to moderate our panel discussion, where Dr. Bush will create a nice discussion between Professor Hoetzenecker, Dr. Staudacher, and Dr. Schweiger. So please, Dr. Bush, the microphone is all yours, and you can start with the panel discussion.
Yeah, thanks for having us all here. I found it's very fascinating presentations. I'm sure we all have questions for one another. So let me start off here for Dr. Hoetzenecker. I want to welcome you to the stage. Start with you with the first question. So Dr. Schweiger demonstrated your robust experience with bridging to transplant using Veno-Venous ECMO, and especially sort of your awake ECMO experience. How do you decide when to deploy ECMO? Is it sort of early before someone really needs to be intubated, or are you waiting until they're just about to be intubated and then do it? And then one of my other questions was with your primary pulmonary hypertensives, which strategy do you more commonly utilize? Are you able to get away with the dual lumen, or do you have to use some of the more advanced therapies?
Well, thank you, Dr. Bush, for these two wonderful questions. I think the first question is a target which really moves. We're trying not to intubate the patients, and we have learned a lot during the last few years. And I think it depends on the underlying diagnosis. In IPFs, you really want to be upfront the problem. You want to cannulate your patients before they deteriorate. So once they're getting unstable on non-invasive ventilations, their CO2 slowly creeping up, that's exactly the time you need to get in. Because we know once they're intubated, they are very hard to be extubated. Can be different in CF patients, for example. They might have a little more safety margin, and you might be able to wait to the next morning. But again, also you want to avoid intubation, because we have also seen in CFs that some of them cannot be extubated any longer, especially if they have a severe pulmonary infection behind their deterioration. So you want to be upfront your problems, and we have started to cannulate early on, and then to be just too late. The second question in regard to pH, that's an interesting question. Putting a PH patient who is failing, has a beginning right heart failure, on Veno-Venous ECMO doesn't help a lot. We need something to not only you not only need to provide respiratory support, but they also need hemodynamic support. So bridging strategies for pH are a bit difficult. Some of them can be stably bridged with VA ECMO, and as you know, the central PALA in overlung might be an option, but you need to sedate patients for this. I'm quite keen on the very recent approach to put in a central VA ECMO through a right third intercostal space incision, and usually you can this is possible to short intubation, then you can wake up patient, bridge them awake, even PH patients.
Dr. Staudacher, your presentation was great, and I was quite fascinated by doing this or performing dual lumen cannulation using transthoracic echo. Oftentimes we have difficulty really getting adequate imaging, especially of the infrahepatic IVC with the TTE, and making sure that we can see where the wire is, not in a vein, and those things. Kind of think Dr. Schweiger alluded to it in his presentation too, that it can be very operator dependent. So what are your sort of pearls to be able to successfully do this? I think maybe it was almost 2/3 of yours were this route, dual lumen route as well. And then what are the indications to use an alternative cannulation strategy?
So thank you for your questions. First of all, I have to confess that I'm a cardiologist, so I'm doing really a lot of transthoracic echocardiography. So perhaps this is because it feels very natural to me to start doing this. But we are using a very stiff wire in order to advance the dual lumen cannulas. And with a stiff wire, and when you can see the wire very good in the inferior vena cava, I feel this is a very safe way to go. And of course, looping is a problem, but as you alluded to, if you know how deep the wire is in, and then you see the wire still in the cava, I think you are very safe from the loop, but you have to know that this is a possibility. To your second question, when we go for which approach, basically, we feel most of the people will need the cannula for at least a week or two, and we don't want to have them too long in the bed, so we want to get them out. So if we can do it, we try to go for a transjugular approach in nearly all the patients. If we have to be fast, and if we feel we cannot lay the patients flat, for example, if they're still not intubated and we don't want to intubate them, sometimes we do the femoral approach also. But this would be like the only reason. If we can't get imaging, for what reason ever, or if we have to be really, really fast. And perhaps one more thing when I'm here, sometimes when we do RDS patients and we go do a lumen and then they develop right heart failure secondary to the RDS, then we upgrade to VVA ECMO and then we use drainage through the dual lumen and they drain very well. But usually in these patients, it's very, very complicated because 2 liters in the arterial line is not enough, so you need more, so you need really a high flow ECMO, and these are very sick patients, so if we can avoid it, we would try not to go for VVA, but sometimes we have to.
And each of your institutions has use of any particular dual lumen catheter sort of, I guess, outweighed others, or as well as how about for each different intensivists or other surgeons at your place? Does everyone also prefer the dual lumen catheter, or is it really operator dependent as well? Let's see, Dr. Schweiger, let me call a name.
It's highly operator dependent, I would say. So we as transplant surgeons, when talking about bridge to transplant, we are clearly in favor of doing this because we see the benefits afterwards with the patients coughing sufficiently after the transplant and so on, getting extubated. And for ARDS and other indications, it's for sure highly operator dependent, I would say, at our institution.
I think some of the people not used to a dual lumen cannula have they are anxious that their guide wire might not go down to the IVC, and I mean that's the main issue. If you don't have a good sonography on the bedside or a TEE around, then things get very difficult. As also in Johns Hopkins, we cannot do fluoroscopy on our ICU. But what we have started in these special cases, we're just using a mobile electronic X-ray, and we're doing 5 shots of X-ray, and you can clearly prove that the guide wire goes down to the IVC, and then you can advance your cannula and you make one last X-ray positioning the cannula, and you have a very safe alternative to fluoroscopy on the ICU. And I think this has really changed the way how we see the cannulas over the last 2-3 years. With the backup of having these electronic X-rays, cannulation has become quite easy on the ICU.
No, that's a great tip for all of us to consider. How has COVID affected your practices? Are you able to use all those X-rays throughout the COVID pandemic for your placement, or in the efforts to minimize staffing? Does it change things or not much?
It has. The practice has increased really, and we have had such good experience. So we increasingly do this. Yeah. I have one question in regard to, just wanted to hear your opinion since we are here, anticoagulation. There has been a very recent publication, the HECTIC trial or HECTIC study from our colleagues from Australia, and they have shown that the platelet dysfunction is different if you have VA and VV ECMO. I mean, it's not very, I would say, I mean, we've all suspected this over the years. Is there any opinion on dual lumen cannula versus 2-site Veno-Venous cannulation in regard to anticoagulation? I'm just curious to hear your ideas about this.
Yeah, thank you for bringing it up. I was hoping we would go in this direction too. I'm sure we all have different anticoagulation strategies. We haven't found a difference between single site cannulation and dual site Veno-Venous cannulation. We manage them similarly. However, I do find, I mean, whether you're on VV or VA, the patients still bleed a lot because of this platelet dysfunction that you're having, and especially noticing if you have more with the dual lumen, sort of more upper or IJ obstruction, that we get a lot of sort of mucosal, nasal, and oropharyngeal swelling, and then some bleeding too. So we cannulate with the heparin bolus, and then we will attempt to use heparin to a goal PTT. But if we see any signs that the patient's not tolerating it, then we're have a low threshold to run the circuit even without heparin. And so most of our people, especially for VV ECMO, end up not being on a continuous heparin drip or any anticoagulation, because as long as you're having a strong flow, and of course, I think with the Crescent getting, I mean, certainly if you're flowing 7 liters, no one's worried about it, but I'm sure down to see even 4 to 5 liters, you would be okay. And we haven't had any difficulty or any challenges with it.
It's great. Yeah, we have the same experience here.
Any closing words? I wish that we were able to talk more. I'm sure we have additional questions. I'm very impressed with both of the institutional presentations we saw today. Very robust ECMO utilizations, pretty impressive.
Thank you very much, dear faculty, for this interesting panel discussion. I really hope we had more time, but it will be for another time, I guess. And this also brings us to the end of this Medtronic Symposium. I'd like to thank the faculty once again. So thank you very much, Professor Hoetzenecker, Dr. Busch, Dr. Staudacher, and Dr. Schweiger for participating in this Medtronic session. We hope everybody enjoyed our symposium, and more importantly, we hope everybody enjoyed every single presentation. Bye, everybody, and have a lovely rest of the day.